everyone, I'm Yasira from M3 India. Welcome to Medicine in Practice. Today we are going to talk about abdominal pain in children. We have our very known guest with us, Dr. Anuj Rastogi. Dr. Anuj Rastogi is a senior neonatal pediatrician from Meerut who has been sharing interesting cases for the benefit of doctors' fraternity. He has a keen interest in neonatology and somebody who believes in psychological health and treating for the wellness rather than illness. Hello, Dr. Anuj Rastogi.
Hi, Yashira. How are you?
Fine, doctor. So going forward, Dr. Rastogi will be answering some of the important questions of this topic. Going forward with the first question. Doctor, can you tell us a difference between abdominal pain, chronic pain, and recurrent abdominal pain?
Yashira, when the pain, children are having pain for more than 3 month duration, this is known as chronic abdominal pain. And when they are having pain once more than 3 times in a month, so these are recurrent abdominal pains. So recurrent abdominal pains are very, very, very common in children.
Thank you so much, doctor. Let's move to the next question. How is the diagnosis of abdominal pain done in the children and when to seek the consultation?
When we see children, they come with abdominal pain, then we, first of all, we take the time of the pain. If they are having pain at the time of going to school, that is one of the most common reason of seeking advice with the doctor. So then we think it is some anxiety related to school or some new friends or some new teacher that is disturbing to the child. So they are having pain in abdomen. So first we try to rule out if child is not having any fever and cough. Then we try to rule out the functional causes of the pain in abdomen, because I hardly find any organic reason for the pain in the whole year of my practice. And usually there are more than 8 to 10 children, they come with the pain in abdomen. What I'm trying to tell you is that the real cause of pain is very, very uncommon in children. Otherwise, most of them, they are having pain because of the functional reasons, because of the social reason, or because of some anxiety. And it is very, very common. Because in abdomen, there are holoviscus, which are nervated through central nervous system along with sympathetic nervous system. So they have lot of, if they have something, some anxiety in their brain, so that may cause pain in abdomen as well. First, if they are having pain, what I do in my clinical practice, I try not to miss 3 important diagnoses. One is appendicitis, that is not very uncommon in children. We do get appendicular perforation off and on in our practice. Second, torsion of the testes, because that is a surgical emergency. If the testis has torn or torsion of testis has occurred, that should be operated within 6 hours of the onset of the pain. Third, intussusception. I will be talking about intussusception in later on. But these are the 3 causes, and how we select this is not appendicitis. We just press on the right iliac fossa and see for the rebound tenderness. Normally, the pain for appendix that start around umbilicus and that transfer to the right iliac fossa, and that limited into right iliac fossa. For torsion intestines, whenever any child who is coming to me, I always see their gonads when they are coming with pain, and if I found something suspicious, fishy at the site of the scrotum, then I think of torsion of testes, or I go for color Doppler for the testes. Intussusception is again that is very common between 3 months to 3 years of age child, and that have a different presentation. But by and large, most of the pain in abdomen, they are functional in nature, and they are repetitive or recurrent, so we take it all accordingly. So if child is not having any fever, then we are little relaxed because it is unlikely to be some significant pain. We do have sometimes hepatitis presenting as pain in abdomen, right, upper quadrant pain, because of hepatitis, loss of appetite, pain, and sometimes we have renal stone also. Very rarely gallstone pain is there. So that is how we see. And in general, we see 2 site, appendicular site and the torsion of testes. And the another dictum is we see if pain is around umbilicus, there is hardly any chance of any significant pathology. If it is away from umbilicus, then there are more chances of some significant pathology. In general, a small bowel disease that causes large diarrhea, and large bowel disease causes small diarrhea. So sometimes with diarrhea, you may have pain also. So it is a big list of pain in abdomen, but most of them, they are having functional pain in abdomen. Another disease which is very, very common, which I show to the parent, Bristol stool chart, that is constipation. So most of them, they give history of constipation because the sleeping time and waking up time is very, very different these days because of the online classes and because children are not going to the school. Even before the COVID time, constipation was very common and it has increased after that COVID time because their circadian rhythm or body clock has changed accordingly because sometimes they are sleeping at 12 o'clock, sometimes they are sleeping at 9 o'clock, and they are waking up around 8 a.m. or 10 a.m. So it has disturbed the bowel movement as well. So most of the children, they are having constipation. Because of constipation, they have pain in abdomen, especially in the left side, or they are having, if they have a severe constipation, they must be having pain while they are eating food. So they have pain while eating food. So I show them Bristol stool chart to the mother or to the child if child is older enough. So I show them the Bristol stool chart and they will tell me what kind of stool they are passing. Because if you ask from the parent, they will say he doesn't have constipation because they feel if he's going to loo, he's having good bowel movement. But most of the time they are going to loo and they are always in hurry or they are passing a small ball of the stool or a small amount of the stool and then they come out. And parent feel everything is okay and everything is good. Child has passed the stool and now child is not having constipation. But these days, different definition has changed. If you are having cracked stool or you are having balls in form of stool, so you are having constipation. For a normal stool, you should have a banana-like stool or you should have a snake-like stool. So these are the 4 type industrial charts. So that is how we make diagnosis of constipation and we treat the constipation, cause of constipation, and child pain abdomen that gets excised. So there is a huge list. Sometimes chest infection can also present like pain in abdomen if there is pleural infection or there is a right lower loop consolidation that can cause pain in abdomen.
Thank you, doctor. Thank you for answering it very, very beautifully and briefly. So moving to the next question, what can be the causes of stomach pain in the children? And if the stomach pain is suspected, what should we do about it?
Most common reason, as I told you, that is a pain in abdomen because of the anxiety. And sometimes there are viral infection also. And these days we are having ultra-modern ultrasound machine. When we advise ultrasound, they will write mesenteric lymphadenitis or lymph nodes in the abdomen. I would like to tell people, doctor colleagues, there are more than 150 lymph node in the abdomen, and we all do have that lymph node. And children, those who are having little increased growth of lymphoid tissue during the early childhood because of the recurrent infection, so they have a little larger lymph node. So this is mostly, it is not the cause of any concern or any cause of the pain. But sometimes we can have small bowel enteritis with lymph node. So that too is not very common. I do get sometimes, and I have to admit them for a couple of days, and they get better. So this is also not very uncommon to have. And most common are 2 reasons. One is anxiety for the school. Second is the constipation. So we diagnose them, and sometimes few ultrasound clinics, they tell us also fecal matter loaded colon, and sometimes they have so much of pain and so much of agony. Parents want to know why he's having so much of pain. They don't correlate with the anxiety of the children. They never realize anxiety could be the cause of pain in children. So you are helpless. You have to advise them CT scan and something like that. And in CT scan, they will only reveal fecal loaded colon. So these patients are chronic constipated patients.
Thank you, doctor. Thank you for answering the question. Let's move to the next question. That is, anxiety due to reasons like can anxiety due to reasons like not feeling well or going to school cause a real stomach pain?
Yes, that causes a real stomach pain because this is because of the sympathetic nervous system involvement. I can tell you one thing. If pain is outside of the body, like pain is on the skin, pain is in the uh, parietal pleura, so it is very easy to localize. But if pain is in the hollow viscous, if inside the abdomen, then it is very, very vague pain, and that club with the along with the peripheral nerves and autonomic nervous system as well. So, because of involvement of autonomic nervous system, they have anxiety that can produce adrenaline rush and that can cause pain in abdomen or vomitings. Vomitings are very, very common, or diarrhea. So it is not uncommon to have like this.
Thank you, doctor. Thank you for answering. Let's move to the last question. That is, what is intussusception? Is surgery the only answer to relieve it?
Yashira, intussusception, because most of the childhood disease they are governed by virus, and we as a team to our other colleagues also we keep talking like if we have surgical emergencies in nursery like diaphragmatic hernia, so we will have 2, 3, 4 diaphragmatic hernia or tracheoesophageal fistula, 3, 4 tracheoesophageal fistula. So somehow I feel even in the congenital anomaly some virus is involved, which we might not be knowing now. So similarly, if we get intussusception, one child of intussusception, there will be few more will be followed thereafter because it is some virus or some disease that causes intussusception to every child. The etiology, basic etiology are these lymph nodes, what I was talking to you a few minutes ago. These lymph nodes, they get enlarged and they invaginate into the intestine. So mostly it is ileocolic, some part of the colon that invaginate into the small intestine. So that causes intussusception. If it is overlooked or it is missed, it may be catastrophic. It may lead to severe swelling of the intestine, that part, and there could be sepsis or perforation, or even the whole intestine get gangrene. So you should not miss. And the classical presentation is this is very common among 3 months to 3 year of age child, and they have severe pain, and in between they are normal. Recently, I come across a child who uh, who was seen in some other town, and he was having recurrent pain in abdomen. His father get ultrasound. Ultrasound was normal. Then he visited to me, and luckily I am having my own ultrasound machine. So I did ultrasound, and I found there's a target. Can you show me the slides which I've
Yes,
shown?
sure.
So this is the intussusception picture when it is taking into the sagittal plane. It looks like that. So it is a sort of a kidney-shaped lump, or it is a compressed intestine or sandwich type of intestine. So this kind of picture we see in intussusception. The next slide. This is this is a contrast enema. You can see at one level, dye has not progressed further. Next slide. This is the most common sign which I could find in my patient. Although these slides are not from my image bank, I have taken it from some book. So this is very common, and I found similar structure. You can see the target sign here. Means there is an intestine in intestine. Even in this slide, the whole intestine is pulled towards the left side. So these are the intussusceptions. These are few X-rays which suggest intussusception. So what I did, I did ultrasound, and it was showing intussusception or the target sign in the right hypochondria. I immediately called to my radiologist friend to do the water soluble contrast. He did water soluble contrast, and it has confirmed the diagnosis of intussusception. Then I requested him to give hydrostatic enema. So what he did, he mix little bit of water soluble dye or gastrographin into the saline, and it was given under pressure. What we do, we put a catheter in the rectum and we give saline with gastrographin from 2 feet height. So that has reduced that intussusception. So surgery was avoided. We did it in 2 patients in last 15 days, and it is doable. It is very well written in our books. So we should not jump on the surgery immediately. We should do hydrostatic or air contrast enema to reduce this. So surgery is not the only answer for intussusception. Only when you have a long segment intussusception, when child is having recurrent jelly stool or something like that, sometime you may require to go for surgery. Otherwise, with this hydrostatic enema, you can avoid surgery. And the only thing, you should have one person who is doing contrast study to you, like that doctor was doing contrast study for my cases. So I requested him, please read in your book and we do this. He was not ready to do that because it is not very common these days to do hydrostatic enema. So I requested him, you just go through. This is simple procedure. Please do that. We can save child from the surgery. And it worked like anything. I'm very happy about it. And that intussusception could be reduced by giving hydrostatic enema. The next day, child had fever also, but that subsided just few medicine, and then now 15 days already been passed, and he's perfectly well and happy. So it is your approach. So intussusception, my clear message for the children, intussusception is should not be missed, and if you diagnose intussusception, you should go for hydrostatic enema. It works. It works. It definitely works. And the clinical presentation of blood in the stool that occurs with the large segment involvement, means when very large portion of the intestine that has passed into the small intestine. Generally, you have ileocolic. The most common is ileocolic, and then another one is ileoileal or colocolic. So, but most common is ileocolic. So you can see the lump on the right hypochondrium, right side of the right iliac fossa. You should not miss this. And what I am trying to give tip to my colleagues: if child is anxious or crying, you should give him some sedative and then let him sleep and just examine him. So that is how you will not miss, because you don't think for a 1 year of old child or 1.5-year-old child being functional, being having pain and crying and coming, getting better and then again crying. So it is quite unusual. And we all colleagues, we all doctor colleagues, we think if child is having blood in his stool, then it is constant, then it is intussusception. So it is not correct. Second, if a child is having green color vomiting, then we will think intestinal obstruction. So even without green color vomiting, without blood in the stool, even then child may have intussusception. That may progress into that condition. If you catch this within time and you go for hydrostatic enema, you can save one child from the surgery. So this is all brief about the pain in abdomen, and otherwise I'm so experienced, I keep on talking about this. There are many stories. Like one story, one child was having pain in abdomen, who came to me and but his pain was not subsiding. I knew that he doesn't have significant pain. But if I ask his parent, he doesn't have pain, he's malingering, he may be having some advantage, they are not really going to accept that. So there was a common story and history for this kind of things. I advised ultrasound, I advised some more tests, and all tests were normal. When he continued to have pain, his grandfather came into my clinic and he asked me, Doctor, why he's not getting better? What is the problem? He's always saying pain in the abdomen. Then I asked him to sit outside and I talked to the child once again. So I asked him, what is the problem? He said, Uncle, I have pain in my tummy. I have severe pain. It's so pain. Then I started, what I am trying to give you tip now. When you want to know something from a child, you don't think him so mature, he can tell you immediately what you want to know. You have to ask him different sector. I asked him, how is your Babaji? He loves you. He said, yes, he loves me. I asked him, how's your sister? He said, sister is fine, but she fights a lot with me. And now he has given me some clue. I asked him, what happened when she fights with you? He said, I beat her. And then what happens? Then my mother beats me. And even when my father came to the home after finishing his office work, then she complained about me. I have beaten to my sister. So he means she instigated to my father also, and he also beats me. Then I asked him, now you are having pain in abdomen. Now how things are going on now? He said, for last couple of days nobody is beating me because I'm having pain, so they are not beating me. So he used this tactics to save himself from beating. So you guess it. So there are different reasons for the pain in abdomen. Another child who has severe pain in abdomen for last many months, he came to me. Then I sent him to my psychologist, and he took the complete history from the child. He said, I watches Harry Potter or some other series. There is one character by the name of Nubi. Nubi has always have pain in abdomen. He said, when Nubi is having pain in abdomen, I'm also having pain in abdomen. So there are different reasons for pain in abdomen that you need to find it out. And I will again reinforce there are very less reasons for significant pain in abdomen in children. So as a clinician, we should know there are anxiety related problems, constipated related problem, or some psychosocial problem. They are causing pain in abdomen to children, and it's very common. You should always be taking care of this. There is no point in giving ofloxacin or anti-tubercular treatment for these lymph nodes, which my few colleagues they advise as tuberculin adenitis or something like that. So I can tell endlessly about pain in abdomen. Any question you want to ask me?
Thank you, doctor. You have explained it really very beautifully and briefly. So thank you so much for answering the questions. You have cleared our audience doubt, and thank you for sharing your knowledge and experiences also. Thank you. We are glad to have you here.